Welcome everyone to our HUR Australia webinar, first one for 2022. Today our topic will be exercise is medicine, and we were discussing how to improve the health and wellness in older adults via exercise. It is my pleasure to welcome you all to our webinar again. It is the third year we're running these webinars, and yet again today we have participants from 20 countries from all the 4 continents. And I'm very happy to have you all back. In the spirit of reconciliation, HUR Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. My name is Ture Karahari-Huisman. I am from HUR Australia and I will be your MC today. Now, today we will be discussing exercise as medicine. Now, exercise is medicine is a sort of worldwide concept that really aims to improve the health of everyone via exercise and really tries to make physical activity a standard part of chronic disease management and prevention as well. We also do know that exercise is a key to happy and healthy aging. So we talk about improved mental and physical health, and also falls prevention, cognitive health, and so on, even living longer. We also know that every exercise is good exercise, but if we really want to treat exercise as medicine, it is quite important to have the right prescription to exercise. So we need to define on how hard we train and how often we train. So we talk often about the intensity, the time, and also the type of exercise. So we talk about these fit principles that sort of guide us. And whilst there is not like a cookbook of exercises that we can just see what is wrong and what we can do prescriptions, but we can give really detailed guidance when we talk about people. So today we're very lucky to have 2 speakers with a vast clinical experience on the topic. They're both allied health clinicians, but also directors from clinics and leading teams that do consist of a number of allied health professionals and also general practitioners. Before we get on going properly, just a few house rules to make sure everybody knows what's going on. So during the webinar, all attendees' microphones will be muted and your videos will be disabled. While our guest speakers are speaking, you're welcome to ask questions, and that really is like the one thing you can do to help us make this a really nice conversation. So in the bottom of your screen, you can see the Q&A section. That's where you can ask your questions. And you can also see the little thumbs up button. If you see another person's question that you think it's really important, press on that thumb button, and then we know, or when I'll be asking the questions during the panel in the end, after the presentations, then I know that the more thumbs up there is, the more people think that that's an important question. So I make sure that I will ask that one. So that's the real thing we can do. Now, we will be recording this webinar and we will later on post it on our HUR Australia website and also in YouTube. And if there are any questions that we haven't answered, we'll also post those questions on the webinar's website. We'll ask our speakers to respond to the questions. So without further ado, it is time for me to introduce our first speaker. Brad McGregor with the topic Exercise and Allied Health Services for Over 50s Wellbeing. Now, Brad McGregor is an accredited exercise physiologist and is the Clinical and Operations Manager at UQ Healthcare in Brisbane, which is a multidisciplinary service promoting longevity and also wellbeing for over 50s. A clinic that's resourced by allied health students at University of Queensland and also supervised by leading academics. Brad enjoys developing systems and processes to improve allied health service, efficiency and effectiveness, and also including the consultancy and mentoring services to allied health and exercise practitioners. So Brad, it's your turn to share your slides and give your talk to our listeners.
Thanks, Terry. I'll just jump in and share my screen now for you all, and then we can just jump straight in. Thanks for those kind words as part of the introduction too. All right, hopefully you can now see my screen, which really I think this screen encapsulates a lot of what UQ Healthy Living is about, which is intergenerational relationships between our clients and our clinicians, and importantly our students as well. And that's a topic that I'll address a little bit later on in my chat today. So first of all, before diving into too much, I thought I'd give you an insight into our vision and mission at UQ Healthy Living, both of which we developed at the beginning of last year when we brought a consultant in to help facilitate a strategic planning workshop. Our vision is to inspire a warm, encouraging community for health, longevity, and a sense of belonging. And I just wanted to draw your attention to the use of that word community, because that's a key aspect that I'll come back to later on when I talk about our intergenerational relationships. And our mission, so the day-to-day of what we do, is to provide personalised and innovative care delivered by clinicians and students to grow physical, social, and emotional health. I describe this to students when I facilitate their inductions on site by describing that they're an integral part of what we do. So our goal or our objective is obviously to provide high level multidisciplinary allied healthcare, but also to provide a high quality placement site for students. Whilst we're not a student-led clinic, we are certainly what I would term a student-facilitated clinic, which is really important. Now, we do develop a model of care here that is interprofessional, and that's something I'll talk about shortly. But on this slide, I've just highlighted the allied health disciplines that we have on site, including EP or exercise physiology, physiotherapy, audiology, dietetics, and psychology, all on site over the course of a typical week. Now, this slide is a little busy, but I think it's important just to show the pathway that clients will take when they come into our centre. So before clients come in, they are sent what we call pre-attendance paperwork that includes or asks a lot of questions around their health status, their medications, their goals, their treatment team, etc. Each of those applications, if you like, will come to me as the clinic manager. I'll review them and then determine which clinician or clinicians they will be partnered with for their first intake assessment when they come on site. Now, I think that's really important because it means that we've got a much better chance of greater alignment between clinicians and clients right up front from the very first appointment. And it also means that we have an opportunity to allocate more than one clinician to an appointment if we feel that interprofessional service delivery is warranted. So that might look like a physiotherapist and an exercise physiologist together with a client in the room at the same time facilitating an assessment, which is what true interprofessional practice is all about. So once clients come into that first intake assessment, which generally takes around 90 minutes, then we work with the client using a patient-centered approach to determine which stream they might go into for their exercise. Now, just starting off on the left-hand side there, you can see where we've got discipline-specific services. This might be where a client is still required to engage in one-on-one services for a period of time. For example, they might be 4 weeks post-total knee replacement. They've yet to regain full range of motion, and therefore we'd recommend that they see a physiotherapist one-on-one for a period of time before they're discharged onto one of the other streams. Our NDIS clients and our Department of Veterans Affairs and team care arrangement clients also fall into this discipline-specific stream. The next stream I'll talk about is the second one from the left, which is the group exercise stream. Now, that's where most of our clinical activity happens, and I'll talk a little bit about group theory later in my presentation. So this is where, after a client has had an assessment and been taken through a program introduction, we'll integrate them into some of our group exercise classes. And I'll show our timetable for you on the next slide. And I'll talk a little bit about how that helps with the biopsychosocial approach to exercise that we implement here. The third stream from the left-hand side, you can see our specialist programs. So we do run some programs such as the GLAD program, which is Good Living with Arthritis Denmark. We also run a diabetes group exercise program and specialty cardiopulmonary rehab programs where we actually bring a cardiac nurse on site to help with monitoring of blood pressure, heart rate, oxygen saturation, pre and post-exercise intervention. And the fourth stream that I'll talk about over to the right-hand side of this image is Member Studio, which is essentially a graduate destination for many of our clients. Think of it like a gym membership, where there are periods of time where we don't provide clinical supervision and clients have more flexibility in terms of coming anytime during our opening hours when it suits. It must be said, though, that our clients can move from streams at any time as their health status may change. So we may, to provide an example, we may have a client who's taken up a membership in our members studio downstairs and they've suffered an acute musculoskeletal injury that requires one-on-one allied health treatment. So they can then transition across to a discipline-specific service for a period of time until that injury is rehabilitated and then re-engage with that member studio membership. All right, so here's our class schedule, just to give you an indication for what a day of clinical activity looks like at UQ Healthy Living. Everything in purple is a healthy living class, so that can accommodate up to 20 individuals at any one time. They're deemed to be low risk and they've been classified as such by our clinicians. And what that means is that they're all implementing their individual program with the supervision of a clinician and students, but they're doing it with others. So that enables them to achieve socialisation and also forms a strong sense of community and camaraderie because they're exercising as groups. Without going into too much detail, a lot of our high needs classes will occur later in the morning towards lunchtime, where obviously those class numbers are reduced so we can provide a more tailored service and provide greater supervision to those high needs clients. And then generally speaking, we'll facilitate our one-on-one appointments in the afternoon. So as I mentioned previously, with regards to clinical support, all of our group classes will have one clinician, and that's either an exercise physiologist or a physiotherapist, and between 1 and 3 students. So this image that you can see at the bottom part of this slide is really a good indication of what a group class might look like, where you'll have a clinician and then you'll have students who you can see in the dark blue shirts helping clients, and sometimes that's on a one-on-one basis. Now, I just wanted to talk briefly around interprofessional collaborative practice and interprofessional education. So I've just put up on the screen here what interprofessional collaborative practice means in the context of UQ Healthy Living. So this is where we have multiple health workers from different professional backgrounds working together with patients and families and carers to deliver quality care. So as I mentioned previously, in the context of UQ Healthy Living, this might mean that we have students from psychology, dietetics, exercise physiology and physiotherapy all in the room with the client at the one time. Now, the benefit to this is it means that there's a reduced risk of miscommunication through handover after the appointment, and it means that we can truly wrap an interprofessional team around the client and put them at the centre of their decision-making around what care they'd like to receive while they're with us. And in addition to that, students that come on site with us will participate in interprofessional education, which is where those different disciplines can learn from and about and with each other. So I mentioned interprofessional team. We will allocate students into teams so they can facilitate appointments together, and they can also engage in learning opportunities together as a team as well. So by the end of their placement here, the physios have a really good understanding around the scope of practice of an exercise physiologist and vice versa. And we feel that really stands them in good stead when they graduate and go out into the community and they work with clients and other professionals in a team setting. All right, now just to pick apart the differences between interprofessional practice and multidisciplinary care, You can see I've highlighted multi-dis on this slide, which is where several professions are involved in the delivery of service or education. They may work closely together, and I'll emphasise that word may. I'm sure many of us can relate to situations where we've been a part of a multidisciplinary team, but there isn't always strong collaborative practice between those practitioners. Whereas collaborative practice, or interprofessional collaborative practice, is a joint intellectual effort of working together in mutually supportive teams. So it does mean that, as I said before, we're really placing a team around the client, and that team can really share their thoughts and their clinical judgments in the context of the same appointment with the patient. And we found that that can be a really strong factor in contributing to improved health outcomes. Now, this image is taken from an interprofessional competency framework from the Canadian Interprofessional Health Collaborative in 2010. And I have put the reference down the bottom of this slide for you to refer to. But I really like the centre of this image, where we talk about interprofessional collaboration as a partnership between a team of health providers and a client. And I really like these terms: participatory, collaborative, and coordinated with regards to shared decision-making around health. This sometimes can be a challenge in the context of UQ Healthy Living, because the majority of our clients are over 70 years of age, and they're used to a medical model of care where they are not the centre of the care model. So their previous medical appointments may have been quite dictatorial, where the clinician is simply informing them of the treatment pathway that they're going to take them down, and they feel like a passive recipient of care. So when those clients come into our collaborative practice model, there can be a period of adjustment because they're simply not used to having a say. So we really have to ensure that we empower them to step up and be a part of that decision making. But when they do, we found there's no looking back. So what makes an activity interprofessional? I'm going to go through a series of questions, and I'd encourage you to use this as a checklist if you're looking to implement an interprofessional model of care at your place of business. So the first question is, are two or more professions involved? The second question is, does significant interactivity between participants occur? The third question, are there opportunities to learn about, from, and with each other? The fourth question, are interprofessional teaching and or learning moments addressed? Now, in terms of how this is implemented at UQ Healthy Living, this image, I think, really captures what I was talking about previously with regards to an empowered, collaborative and client-centred service. So in this image that I've got up on the screen, you can see where the client is well and truly in the middle of the care model, and we have client safety and quality up the top as part of a prerequisite, if you like, and also the collaborative practice element that I've just spoken about as well. And I really like this quote by Verma on the right-hand aspect of this slide, where it says that the idea is to flatten the hierarchy and create a circle of people, and in the centre of that circle is the patient. And I'll indulge a little here and just talk about an experience that my father encountered when he consulted a specialist a few years ago that implemented a very patient-centred model. So at the consult, the clinician reviewed the tests and the scan results, and then said to my dad, okay, so we've got a couple of options here. We can go down option A, and the pros and cons of this are as such, or we can go down option B, and here are the pros and cons. Now, which way would you like to go? And my father really struggled with that, because he was used to a model of care where he was simply told what the care plan would be, and he was just going along for the ride. So his question back to the clinician was, okay, so what would you recommend? What are your thoughts? But I'm pleased to say he called me after the consult, and I said, Dad, that's fantastic. Did you speak up and really jump into that opportunity? And he said, no, I didn't. I said, okay, so this is a more contemporary way of delivering care. And when you go for your next follow-up, I want you to have a few questions, and then you can feel free to have a say and make your decision after you've spoken to the clinician in a bit more detail. Now, I will talk a little bit about group theory and why we chose a model where we deliver a lot of our clinical activity with groups. we've found that this creates a strong sense of community and what I'll refer to as tribalism, and it improves self-efficacy. So one of the comments that clients will make when they come into our facility is that they feel comfortable when they see their tribe here. In other words, they're not walking into a 24/7 gym where they're seeing next to nobody that's representative of their stage of life and might be facing similar clinical challenges that they're facing. So when they see other people, they immediately relax. And they know that they can share and they can empathise with people that might be facing similar health challenges. They can share experiences. And I've put a quote in here from a client that I spoke to last week who was coming to our clinic and then had a period of time off around the COVID wave coming through Brisbane and Queensland earlier this year. And when she re-engaged, this was her quote. She said, "Getting old isn't for the faint-hearted." And in that moment, I realised how important it is to have not only clinicians and students, but also a group of peers that you can share those experiences and those thoughts and those fears with. And to that point, engaging in groups really helps clients to look out for each other. As a case in point, one gentleman in one of our classes will know if someone hasn't attended his class for more than 2 weeks in a row, and he'll proactively give them a call and just ask how they are and when they might be coming back. And that's far more powerful than us as clinicians or administrators making that phone call. The social interaction I've previously mentioned as a really important aspect, particularly when we're talking about some of our clients, unfortunately, are quite socially isolated. And a few people have mentioned to me that we're the only human interaction that they've had that day. And whilst that might sound pretty sad, and the reality of it is that it is, but if we're happy to give them some interaction and help them with that, that human side, then that's a win. And with regards to ownership of the facility, we can do this and create this community via a couple of different modes. One is via focus groups. So if we're looking to bring in new interventions, new clinical services, we'll grab a cohort of our current clients and run some questions past them so they can give us some feedback. And then as a result, they feel a greater sense of community and ownership. So the vernacular they tend to use is around my clinic and my UQ Healthy Living, which I really love to hear. Now, with regards to independence, I will talk about this more on the next slide, but just to transition to that, I will say that it is more than just the exercise session that is important for our cohort. Now, I'll talk about that in a little bit more detail here. So in order for someone to participate in a clinical encounter at UQ Healthy Living, these are all of the tasks that they need to complete over the course of that visit. So they need to get themselves up. They need to prepare for the session. So get dressed, have something to eat. They need to ensure or organise travel to the venue, whether that be driving themselves, finding a park, or organising public transport. Then they're participating in the session. Then afterwards, with colleagues, they may go and have a morning tea and then pick up a few items from the shops and then organise to travel home. Now, all of those tasks are helping to facilitate independence. It's not just the session. Sure, we look at the biological aspect of the BPS model in the session itself, but by facilitating all of these tasks around the session, we're really hoping to build resilience and facilitate more independence for our clients. Now, intergenerational relationships was something that I spoke about at the outset, and I'll just talk about this for a moment because I think this is a little piece of magic that happens here. When I first commenced employment at UQ Healthy Living, I asked a few of our clients why they come. And this was one of the responses that came back to me was that, oh, you as clinicians keep me safe, so I'm pleased that you're here, but the students I really like engaging with because I have a different relationship with them. The students are the same age as their grandkids, so they feel a strong sense of empathy and mentorship towards them. So they're mentoring students not only clinically, but also with regards to life skills. And what I mean by that, there's, I'll give you an example. There's one lady that will come up to new students when they're commencing a placement on site, and she'll start explaining to them how she likes to be communicated with. In other words, Don't be on your phone or your laptop. Make eye contact, acknowledge me by my first name, and do that each time you see me. So students are therefore, they're not only learning the clinical skills, but they're learning life skills that our clients can give them from their previous experiences and desires. And again, I think that helps to hark back to that patient-centered model of care. We have a lot of alumni that come here as clients from the University of Queensland, and we have a lot of retired clinicians that choose to come here as well. Now, the benefit of that is the health literacy is obviously very high, but we also can give them a sense of purpose. So imagine us giving our lecturers that come here as clients back the best part of their job, which is the mentoring. So forget about the marking and the lesson prep, which, let's be honest, not many academics like to do, but they actually get to mentor students, and that provides a really strong sense of purpose. Now, just to finish off, I thought I'd delve into the exercise is medicine theme from a clinical perspective. And I really like this infographic. Again, the reference is down the bottom of this slide, titled Neuroscience of Exercise. And I just wanted to draw your attention to some of the disease states at the top: Parkinson's, Alzheimer's, and major depression. And you can see the brain in the middle of this infographic. And then you can see three key neurobiological processes towards the bottom, which are all facilitated by exercise. So we're talking about neurogenesis, angiogenesis, and neuroplasticity. Now, we know all of those are key neurochemical processes that occur as the result of exercise. And I'm really excited about the role that those processes will have in managing those conditions. And finally, this is a slide that I've shown to university students where I've presented at previously. I really love this study that was presented in a Wendy Suzuki TED Talk a little while ago. This is a functional MRI of two cohorts of students. One was sitting quietly, which is to the left, and two after a 20-minute walk. And just look at the increase in activity in the cerebral cortex of cohort number 2 after a 20-minute walk. And obviously I use that in the context of students, but I've also shown this to some of our clients as well, just to show even the acute benefit of a seemingly low dose of activity in terms of neural activity and upregulating neural function. And I'll just leave my contact details up there with regards to the website and email address. And thank you for the opportunity to present.
Thank you so much, Brad. It's really fantastic, and I really like your clinic for the fact that you really put the client in the centre, because that is so important. And also allowing the students to understand how important it is to work with others, that you're not just by yourself. And I think especially with type 2 diabetes increasing in our society, especially after, you know, we've been all at home for 2 years and working from home. So we move a lot less because we don't have to go to the printer or go to a meeting. We just sit by our laptops for the last 2 years. So type 2 diabetes is another one where you need to work together with the exercise physiologist and the physiotherapist and the podiatrist and the nutritionist and the diabetes nurse. So there's a lot of these now very common diseases because of our lifestyle that really require everyone to work together. So that was really fantastic, and I think we got really great advice from that aspect. And yes, to everyone, there was a comment that the slides are a bit blurry. We will post all the slides up on our walls. It's a bit of a technology, and also I heard that my voice is, the internet in my house is fluctuating at the moment. So apologies for that, but that's the technology that we can do nothing about. Now, we won't pose any more questions to Brad yet. We'll do a panel in the end of both the presentations, but rather at the moment, we'll move on to our next speaker, who is Sam Whaley. Sam has a speech or a talk titled GPs, so General Practitioners and Exercise Physiologists, Bridging the Gap Between Exercise and Medicine. Sam is an accredited exercise physiologist and director at MedHP, a health and wellness hub designed specifically for over 50s. Sam, after having worked extensively with an older demographic, Sam has a wealth of experience in exercise rehabilitation, including the musculoskeletal and chronic illnesses, as well as oncology. Sam is passionate about the need for good health and well-being and strongly believes on the effective exercise interventions that can positively influence quality of life, also giving his clients their health and body back. Sam, I just no, I wasn't on mute. I got scared for a moment that I was on mute. Along with Meds HP, Sam has also published a book, Age is an Attitude, that then provides fitness advice for readers in their post-junior years. Now, without further ado, Sam, the stage is yours.
Thank you, Turi, and thanks, Brad. I look forward to jumping on a plane, coming to a warmer state, but also checking out your space. So, yeah, very interesting. But hi, everyone. Thanks for having me. I'm very happy to be here talking to you about our new business, Medical High Performance. Just a quick look at what we'll touch on today. But before we jump in, I guess I just wanted to give you some context before we get started and a quick overview of the gym and how we got started and where we're headed. But for MedHP, from day one, everything evolved pretty quickly. And it started after a fairly informal chat with one of my now business partners, Nick Kokotis. Nick is a principal GP and senior partner at two very large Melbourne-based medical centres, and certainly one of the true believers when it comes to exercise. We've known each other through professional networks, and I'd seen plenty of patients from the clinics over the years working in private practice. So the relationship was already there. And Nick and I spoke on the phone. He rang, and the conversation, I guess, quickly steered towards setting up an over 50s gym, but not just any over 50s gym. It had to be the ultimate over 50s gym, and it had to be sexy as well. So we had a few KPIs to reach. As timing would have it, I'd recently just written and published my book, Age is an Attitude, which is all about exercise and wellbeing advice for the over 60s. So we were speaking the same language straight away, and I was on board. I guess we had very clear visions and ideas about the exercise space that we wanted to create through personal experience and also professionally. It was important for us that we created a space that was not one-dimensional, and we wanted to have a facility that was available and accessible for everyone. And we needed specialist strength training equipment, which is why we have the HUR equipment. But we also wanted to have a free weights and a functional space. We needed to have cardiovascular equipment, exercise classes that were more geared towards an over 50s demographic, reformer Pilates, active adventures and education nights. And I suppose touching on what Brad had mentioned about the social side of things, COVID hit Victoria very hard as well, and having a social and group-based function in our gym was important for us. So here we are, 4 or 5 months later. We're still reasonably fresh, but a bit excited to be off and running, and here we go. So a little bit more about us. MedHP, Medical High Performance. We're a health and wellness hub, and our aim and our goal is to bridge the gap between medicine and exercise. And I'll touch a little bit more on that in a bit. We're essentially a clinical gym, and we cater more specifically to an over 50s demographic, which seems to be about the time where people realise all of a sudden they're not bulletproof, and they might be a bit more vulnerable than they thought they were. So in line with that, we were placing a real emphasis in trying to create a space and a venue that's safe and nurturing and supportive of our patients' or clients' exercise needs. But not only that, we wanted to create a space that built some hype around exercise and got people excited about moving their body, and had potentially shifted some of the barriers that might have gotten in the way of them joining a gym or exercising in the past, or that they'd fallen out of sync and they were nervous about starting again. So it was important for us to remove the intimidation or fear factor that might come with walking into a gym space. I guess in saying that, until you're middle age, you can probably walk into a gym or an exercise class and do a session without too much fear of damaging yourself. And I think over 50, this definitely changes, and suddenly there's a vulnerability, and you might have a health condition or an ailment, an injury that needs to be managed. and you're not quite sure where to start or what to do or how to go about it. So we needed to create a space that would cater for this. And ultimately, we wanted to help people become the fittest and strongest and healthiest version of themselves. And so we sort of moved on, and essentially our mission in that regard is to redefine aging, and in some ways through exercise, reverse some of the age-related decline in people's bodies and their health. So being a clinical gym, exercise physiology goes hand in hand. Now, our exercise physiologists manage all clients or patients coming through the doors. So whether that's referred via a GP or whether that's privately, whether that's to speak to the EP specifically or whether that's just to join our gym as a member, everyone needs to see the exercise physiologist first. And that's just a touch point to assess their medical history, their exercise history, and work together with the client, with the patient to come up with an exercise plan and program that's going to be appropriate for them and their needs. We're very much goal orientated for the client, and having a program that aligns with their goals and their expectations is an important part of our service. Moving on and complementing the exercise physiology, we have gym memberships. So most people who join our gym, as I mentioned, they'll see the exercise physiologist first. They're assessed with the exercise physiologist and programmed, and there might be a period of integration, I guess, where the exercise physiologist will work with the person in a one-on-one capacity until they feel comfortable and confident with their exercise, after which we can orientate them into their gym. And from that point in time, they can become an independent gym member, whereby following their program, they can come and access the gym whenever they like. They have access, and they follow the program that's been set for them, after which every 6 to 8 weeks, we review the patient, we monitor their progress, we reevaluate their goals, and we'll update things accordingly. As Brad touched on as well, I think the social side of exercise is a very, very important part of things. And certainly for over 50s demographic, the engagement that they have and their camaraderie and the tribalism that Brad had mentioned, I think is very strong, and it certainly does improve efficacy, and they do develop friends, and they do really love it, and it's exercising with a smile on your face rather than a grimace. And so in that aspect, it was important for us to have a group class offering. We've got a few different ones. Move is our active aging class, and it's a combination of strength training, cardiovascular training, balance, flexibility, all the things, I suppose, that keep people moving well and feeling well. Reformer Pilates was another offering. It's hugely popular, and I think it has a nice clinical tie-in and a demographic over 50s tie-in as well. So we offer Reformer Pilates classes too. Moving, I suppose, towards exercise groups that have a bit more of a clinical focus and address risk factors that are associated with aging. We run a balance-specific class called Best Balance, which is falls prevention, and it's focused on all the things that will get people a bit more confident. There's a bit of gait retraining, there's lower body strength, there's reaction drills and balance drills, and it's all sort of whipped into a more engaged and interactive class that they can do together. And I think having peers who are in a similar situation to themselves is reinforcing for them, and it certainly helps improve people's confidence and put their head down and do the work that they potentially need to do. And then more clinical groups as well. So type 2 diabetes, osteoporosis, arthritis, osteoarthritis, women's health and postmenopause. So a bit more specialised and specific in their exercise application, but certainly a very important part for the over 50s demographic. Active adventures, and this is touching on the social side of things, and I suppose us wanting to create a community and a social aspect to our gym and the programs that we run. So Active Adventures is, I suppose, having people align with a specific task. So whether that be a walk, or whether that be a hike, or a mountain bike, or a swim, or a paddleboard, people set themselves and they're training for a specific purpose with a goal in mind, and then we actually go and do it together. So it reinforces exercise, not necessarily just for a clinical purpose, but for a practical and an enjoyment purpose as well. So the satisfaction and the sense of achievement that people get from setting a goal and achieving it is huge, and it only reinforces you know, why a good exercise program is important for them. Moving on, and education nights, and I guess this is probably the first slide where we can really start to see the medicine tie-in and the GP tie-in that has become a very strong and very important part of our business, and something that sort of sets us apart from other gyms. So education nights is a night where it's centered around a specific topic or a clinical condition. So that might be sarcopenia, it might be a metabolic condition, it might be a neurological condition. It can be more general around nutrition or sleep. But the idea is that the night is led by a doctor or doctors, and they're made available to all our EP clients or gym members. And essentially what it is an opportunity for them to access advice and medical information from experts in the field. And it's run as a collective presentation where we've got a medical specialist, we've got a general practitioner GP, we've got allied health professionals, all giving their input into the relevant condition and giving advice on what they consider are important factors for successfully managing it. Moving on from this, the GP to EP process is where we're trying to bridge this gap and hopefully get people moving more, get people encouraged by exercise, and removing the fear factor, as I mentioned earlier, around exercise. So I guess exercise is medicine. It's a huge push, and working as an EP, we're very fortunate to be at the forefront of the exercise is medicine message. We're the converted. We know what a potent tool exercise is for improving a person's health and well-being, and the positive influence it has on just about all chronic illness. Is considered such an important part of successful management for diabetes, for osteoporosis and pain, and mental health and dementia and cardiovascular disease. The list goes on and on and on. It truly is a wonder pill, and it is certainly a message that I think more people need to know about, and surprisingly probably don't know as much as what they should. And so the gap, I guess, in the general population's awareness and knowledge around exercise is something that needs to be addressed. And part of the challenge as an exercise physiologist is helping the unaware, helping the uneducated, I suppose, around exercise become woke and embrace it and start to incorporate it into their lifestyle so that they can feel the benefits of it. Now, hearing about the medicinal effect and how good it is probably needs to come from more than just the EP. It's like hearing advice from your parents. You need a broader spectrum. So being told by your doctor, your GP, that you need to exercise, I guess is one of the strongest and most influential factors in getting people to make the first and necessary steps towards exercise. So I love this quote, and it's Nick, my business partner's quote, and he says it to a lot of his patients when they're asking him questions around their health. So exercise is the answer, and ask me the question, and I think who can argue with that? Simply telling someone that they need to exercise is sometimes not enough, and some people need a push in the right direction to get the right kind of advice. And so this is how we've tried to help with MedHP. If the doctor identifies a health condition where exercise can be of benefit, then the patient is open to the discussion or open to exercising, they're able to be channeled straight into an appointment with an EP at our gym. And essentially, like, this is what MedHP was created from. We've got a very tight referral process with the doctors, and we're able to streamline the patient into an appropriate exercise or rehab program that's going to sort of optimize their health outcomes. MedHP, we're tied directly to two fantastic medical centres that are holistic and proactive in their patients' health. So Bluff Road Medical Centre and Bayside Family Medical Centre are two clinics which we're very closely associated with. And across the two clinics, we have 35 GPs, over 10,000 patients, over 50, and 45% have a chronic health condition. So we're talking about big numbers, and there's definitely a need to try and help and care for these people. So from a pathway perspective for these patients and giving them options, the clinic does 50 care plans a week. Now, for those who don't know, a care plan in Australia is a Medicare subsidised initiative where patients have access to allied health services for chronic conditions. It makes allied health accessible and cost effective for them to at least get started and get the ball rolling. And then they've got some options moving forward from there. So it's an important part of getting people in the door and starting to better their health. With the clinics, the care plan process, each person gets given a questionnaire before they get started. There's a series of health and wellbeing questions in the questionnaire, and two of the questions touch on exercise. The first being, do you think you exercise enough? And the second being, do you want to know more about exercise? Now, if they don't think that they exercise enough, and if they do want to know more about exercise, then it's an automatic referral into MedHP in our gym, and we can sort of help them from there. Another part of the questionnaire is centered around balance. Now, I know for over 50s, this is certainly a common conundrum and something that most of them are aware of and want to be on top of before it becomes clinical. So if they identify their balance being an issue, it becomes an interdisciplinary approach in that they're referred to the physiotherapist for a balance assessment, but also to the exercise physiologist and MedHP for an exercise intervention. We have the HUR, we have the Senso balance trainer, and we have a clinical space and a big space where we can sort of apply all those exercise principles and help them on their way. I think, you know, in all of this sense, the doctors just want their patients looked after and cared for and have peace of mind that they're sending their patient to a venue where they're getting all the kind of care that they need. The feedback loop in that sense from the patients is very, very positive. They love the environment, they feel better, stronger, they're happier, they're more secure, and often within quite a short space of time. So 1 to 2 months, they've got the exercise bug, and then from then on in, it's quite easy to keep them engaged. I think that investment in their health and their independence and control over their bodies and their exercise routine is a very important part of that. So the close collaboration and synergy between GP and EPs is fantastic and clearly beneficial for the patient outcomes. Everyone's working together on the same page for the same cause, which is for the betterment of the patient. And the patient gets access to a level of care that is hard to beat. And then I guess from a professional sense, it gives the exercise physiologist a greater insight and capacity to learn more about the medicine side of a patient intervention and work collaboratively with the GP to target the things that they want addressed as well. And on the flip side, I think when the GP sees a happy and healthy patient returning to them, it reinforces the important role of exercise and the fact that they've sent them to the right place. I suppose what it's also allowed us to do is become a bit more specific and tailored to what a GP might necessarily want, or a collective of doctors. An example of that, one of our female EPs had spoke to a female cohort of doctors at the clinic where they identified the need for a postmenopausal, a women's health program, pelvic floor and bone health and cardiovascular health, and the things that can become sensitive and can become a problem after menopause. And so that GP feedback, and we've been able to implement a program according to what they want. And that's the same moving forward with sports doctors wanting to run specific exercise groups, got weight loss doctors wanting to run exercise groups centered around weight loss. So it does work hand in hand, and I suppose we can have a direct access to the doctor, implement the programs that they want to see as well, and it feeds back to the patient as well, and they can reap the benefits. So it really is an exciting time to be in the exercise space, and I think there's certainly a shift in people's views around exercise. We can just keep reinforcing that and making that better. I think exercise as a mode of therapy and good health has quickly evolved from an optional to a necessity. And it's a great opportunity for us working in the industry to roll out initiatives that are going to help and have a positive influence on everyone's health and well-being. So thanks for having me today. I hope that helped. We're very new to the scene with MedHP. We've only been open about 5 months, but certainly look forward to checking back in a year or so and having more exciting things to tell you about. So thank you.
Fantastic. Thank you so much, Sam. There's actually quite a lot of questions that have come in, but I thought we'll go through that. Brad's been quite busy. Actually, Sam, you don't have to share any more of your slides. Yeah, awesome. Brilliant. Yeah, so there's quite a few questions that have come through, but I thought we'll start by just a simple question, just to clarify on everyone. In simple words, what do you both think is the difference between exercise and exercise as medicine? Just a few things. What is the difference? Why do we use this term, and why is it different than just me going for a walk?
It's a good question. I'm happy to take a swing at this one first, if you like, Sam.
Go ahead.
From my perspective, exercise is medicine is in the domain of treating a pathology. So if we have a diagnosis, then we can be reactive in terms of using exercise as a treatment plan, or alternatively, I think exercise as medicine can be prescribed in order to prevent the onset or commencement of a certain pathology. So as a case in point, if you had a strong history of heart disease, then that could be a sound rationale for someone to commence exercise as preventative medicine as opposed to exercise as reactive medicine.
Yeah, I completely agree, and I think it's certainly exercise for a purpose, and it's exercise with a specific clinical goal in mind. And I think applying it in that sense is important because, you know, I see patients who come in with osteoporosis and they've been swimming or they've been bike riding, and so there's no weight-bearing activity involved, there's no resistance training involved, which, you know, as we know, is a very important part of managing the condition and preventing sort of further deterioration. So having that a direct application into a clinical condition, medical condition is what sets it apart from just moving.
I think that's such a key point, and also knowing that there's so many times if you tell the people to go to the gym and they will say, I'll never go to the gym, I'll walk and I'll do my gardening. So it can be sometimes quite difficult to encourage people to go there, to make people understand the difference actually when you go to the gym and you follow an exercise prescription. I'm just going to go through a few of the questions that have come through, and I know, Brad, you've already started responding, but thought if you both want to elaborate a little bit more. There was one that came, do you find the client ownership element can be a double-edged sword? Where Brad has then responded, yes, it can. I think it's where educating the client around the dose-response relationship is important. And I just wanted to bring that up again because that's exactly what we're talking about, the difference between exercise medicine and the FIT principles, and teaching people to make them understand really about the intensity. Just checking if you two want to elaborate on these questions, if you think that the ownership element can be a double-edged sword.
Yeah, and thanks, Mick, for posing that question. From my perspective, I think there is an element of patient education, and that I think some clients need to go through the stages of readiness to change before they're ready to step up and be a part of a collaborative care model. And that might take a little bit of time. And I think as clinicians, we need to have our radar on for those clients that are used to being a passive recipient of care. And we need to gently take them along that journey to a point where they feel comfortable having a say and being an equal partner in the care that they receive. So I completely take on board what Mick has said. It can be a double-edged sword. I think if we launch straight into facilitating that ownership from the word go when a client isn't quite ready to step up to that mark, then it can set back outcomes potentially.
Yeah, I totally agree. And look, I think it's very much a case-by-case basis, and having that EQ with the patient and understanding what type of person they are and sounding them out before you either give them the freedoms or you don't, I think is an important part. And education and making them aware of the role exercise will play for them, I think is a big part of helping them embrace it and make the right decision. But some people need to be pushed and some people need to be pulled back. So there is discussion in that regard, and having your finger on the pulse and understanding the patient, I guess, before you see them one way or the other.
Excellent. Now, before I go to one question, there's actually a comment from Sam's business partner who actually says here, really well, because we talked about the collaboration with the GPs as well. And Nick, actually, Nick, you know, our previous newsletter was about exercise as medicine, and Nick had a great story about his views as a GP. And Nick actually just states here that as doctors, we prescribe medicine, but what they really need is exercise. They won't achieve their goal until they exercise, and this so is such the truth. And again, I mentioned diabetes before, but often you can actually get rid of your medication if you exercise properly. And once we get the goals, and that's where the collaboration works. Now, there's quite a few questions about funding and funds and affordability and everything else, but what I'm going to, because we have limited time, I think if you, again, I think we have the answer from Brad who started this one, but Edward asked, how do you guys feel this approach, so large facility to lots of equipment, lots of input from various professionals, could be adapted to work for the large number of people who are on government-funded programs, such as home care packages or CHSP, with limited funding for things like physio and exercise sessions, and with limited ability to access the community? So again, if they have carers or they're required on one-to-one assist. And again, Brad has written his answer there, but if you guys want to elaborate, and I think the reason why I really want to ask this is because also when we look at ResiCare, funding is about to change, and the allied health, I'm just about to post on our LinkedIn page, it is affecting the funding. So I think that's a really nice question. So if you want to elaborate on that one.
Yeah, sure. And I think it's important to acknowledge that not all compensable schemes loan themselves to an interprofessional model of care. But I think we're starting to see that shift, and I'll refer to the NDIS scheme here in Australia, which is the National Disability Insurance Scheme, does have some potential to incorporate an interprofessional model of care where we do have plan managers that will help a participant to invest funding in health initiatives that will lead to improved health outcomes. I think if you can make a really strong case and go to a plan manager and then put forward a model of care that you think will enhance outcomes for that client, I think there could be some opportunity for interprofessional practice there. But by the same token, I'll also admit that many other compensable models in Australia unfortunately don't loan themselves to interprofessional because they simply won't fund more than one clinician providing a clinical encounter at the same time. So in our context, that's where we have the luxury of using students from different disciplines. They don't cost us anything and they don't cost the client anything. So we can still facilitate interprofessional teams without it costing the client for every clinician that's in the room.
Yeah, that's right. And it is certainly a challenge. And, you know, through the NDIS and the initiatives with that, it does sort of make it accessible to a point. and with some Medicare subsidised or clinical conditions, you might be eligible for some rebates and some discount, I suppose, on the services that you access. But it's certainly the challenge and getting guidance and assistance with the kind of exercise or care that you need in a budget conscious way. I think moving forward, things are progressing, and I suppose exercise, from speaking more directly about my own work, is becoming a little bit more accessible, I guess, through some online or digital platforms, but it's still got a long way to go. And I think moving forward, we could probably do a lot more and look at sort of other funding structures that are going to make it sort of applicable and available for everyone, whether that's at home or in a gym space too.
Excellent. And also with the funding, I mean, our previous webinar, so the November 2021 webinar actually focused on funding. So if, if you're keen on look at the funding, if you go to our HUR Australia webinar site or our YouTube channel, look at the webinar of November 2021, that is about funding. So we had Dr. Tim Henwood then really discussing the funding options within Australian space and going through that. Now, one last question. We just at 5 o'clock. There's something I wanted to ask because before this, we actually did an interview for Brad for our website and also for the newsletter about the FIT principles. So, like I mentioned in the beginning, we often talk about the intensity and frequency. So, when we prescribe exercise, we talk about the sets and the repetitions and the resistance. But importantly, then Brad actually mentioned a lot about the timing. So whether you really play with the eccentric and concentric phase of the movement, which then sort of leads me more into the question, because there's some studies by a group where they only trained on the eccentric phase and found really nice results, especially on power. And with this, an extra point, when we had the sarcopenia lecture last year, then we had Robin Daly, Professor Robin Daly from Deakin actually mentioned that we first lose the power before we lose muscle strength and muscle mass. So I want to take it back to then Brad and Sam. Like, we know that there is no cookbook. You can't just go and say, this is my diagnosis and my age. This is the right prescription. It's not like baking a cake. There still is the individual aspects. But how should we take account this timing? Like, does the timing then more relate to the eccentric and concentric? Can we relate to power? Are there any specific chronic diseases or injuries where we should be then training in a particular way, especially considering the timing, rather than increasing sets or reps?
Yeah, it's a good question, Terry. And I think the first point I would make with regards to tempo is it is a variable that can be manipulated to achieve overload. And I think by default, we always lean towards changing exercises and changing volume in terms of sets and reps and changing load. And I think often tempo and recovery are probably two of the acute exercise variables that we neglect to manipulate on a regular basis. And a most common tempo is normally expressed in 4 numbers. So the first number is the eccentric phase. The second number is the pause at the end of the eccentric. The third number is the concentric phase. And then the fourth number is the pause at the end of the concentric. So you can get quite complex in terms of tempo, but linking it back to your second question, which is how it can be manipulated, we know that there's some good evidence around eccentric loading to improve tendinopathy outcomes, for example. So I think maintaining currency with research in terms of how the tempo of training can affect certain pathologies can be really beneficial. And also in certain disease states where we know that a longer tempo can improve time under tension, which can then have positive benefits towards sarcopenia. So I guess to round out my answer would be, don't be too quick to just use a change in exercise as a way of manipulating a program. Look at tempo as well, because that can have a significant impact on the physiology that we're trying to manipulate.
Yeah, I couldn't have said it better myself, and I think that's exactly right. It's certainly one of the, we know that the body has a greater capacity for load under eccentric phase, and manipulating that and using that as a training tool, I think is important. And individually programming someone, and it's not always as simple as this person's 80 years old, they've got sarcopenia, they need to get stronger. There's so many other conflicting factors or complicating factors, that they might have, an arthritic knee, or they might have whatever it may be. And so in theory, we need to apply a training principle that is going to be good for that person and achievable for that person, and is going to progress that person, and starting with the basics, and then starting to use, as Brad had said, tempo and timing is a training variable to continue the stimulus.
Fantastic. Now, sadly, we are running out of time. The Q&A section has been quite active. There's a lot of great comments from people and questions, and shared links to research, which is really fantastic. So it's nice if we can create this platform where people share their professional expertise and everything else. Sadly, it is time for us to wrap up. Again, some of the questions were about specific exercise prescriptions. But we've been running these webinars, now this is the third year, so all the slides are there. If you look at the webinar, scroll down and there's links to the sites where people come from, and also research and everything else. So there's a lot of clinical advice there. But we'll continue. We'll have another webinar later this year, probably in November, where we're going to be having more speakers. But now it's time for me to thank you so much, Brad and Sam, for joining us. It's been fantastic, and we greatly appreciate you coming in. And I want to thank absolutely everyone who joined. It's amazing that we still keep on getting people from 20 countries joining in, which is fantastic for us. And we really are there for the mission to really spread the word around the proper exercises, and always try to find new discussion points. And if you have something you want to ask, or if you want to have a topic, please send it to us to our address, to our email address, and we'll look into this. And we'll really, the purpose here is to share the knowledge and try to make people live healthier and happier forever. So I say thank you, and thank you to the speakers, thank you to the audience, and we'll see you again in November this year. Thanks.